Okay, everybody. If the presenters are ready, then we can just start.
Okay, Doctor, can we start?
Yeah, we can start.
Okay.
Can you
good
hear
morning,
me?
Abid. Yes.
Because I'm using my earphones. Can I?
Yes, we can hear. Yes. Okay, I'll start the presentation. So good morning, Abid, to our supervisor, Dr. Chan, and my fellow friends. Today we are from Group 3A. We are going to present a case-based seminar, one on several topics, which are the first one is child who is cynos, child who is jaundice, child who is pale, and child who is having shortness of breath. So me myself will present the topic of child who is cynos. My name is Najam Tadwaraza. So next. So this is my table of contents. Next. Okay, for introduction, cyanosis is defined as a bluish discoloration of the skin and mucous membrane due to an increased concentration of deoxygenated hemoglobin in the capillary bed. So cyanosis develop when the concentration of desaturated hemoglobin is at least 3 gram per deciliter centrally or 4 to 6 gram deciliter peripherally. Just so it is a general sign of significant hypoxia. So it is best seen in areas with rich superficial vasculature with thin underlying dermis such as lips, nose, sclera, oral cavity, extremities, and tips of fingers and toes. Okay, next we move on to types of cyanosis. So it is divided into central and peripheral. So central is defined as a generalized bluish discoloration of the body and the visible mucous membrane. So the mechanism of action is basically due to hypoxia secondary to increased deoxygenated hemoglobin, or the other mechanism is due to presence of abnormal hemoglobin, for example, in a case of methemoglobinemia. So for peripheral, this is due to, it is a condition where bluish discoloration of the distal extremities. Sometimes it could involve circumoral and periorbital area. So the mechanism of action is basically due to increased extraction of oxygen, which result from the sluggish movement of blood circulation of the peripheral tissue. So next, so these are the presentation of the cyanosis, the peripheral and the central cyanosis. Okay, so we move on to causes of cyanosis. Basically, the most common cyanosis in infants who will be eventually admitted to an ICU would be due to respiratory distress syndrome, sepsis, and cyanotic heart disease. So the system that are likely to be involved would be mainly the respiratory, circulatory, and the rest will be categorized as others. So first we take a look at respiratory cause. It is divided into 4 causes due to decreased inspired fractionated inspired oxygen. For example, in the case of carbon monoxide poisoning and due to smoke inhalation. So next is upper airway obstruction, for example, in the case of croup, epiglottitis, foreign body aspiration, and traumatic disruption. And in the case of impaired chest wall and lung expansion, for example, in the case of open pneumothorax, hemothorax, flat chest, and intrinsic lung disease such as pneumonia, empyema, cystic fibrosis, so and many more, asthma included as well. So we'll take a look at the circulatory cause next. The first category is congenital heart disease. So as we have been taught before, congenital heart disease, we must remember the 5 T's: the tetralogy of Fowler, TOF, transposition of great artery, TGA, tricuspid atresia, truncus adhesive, and total anomalous pulmonary venous return. So TOF is the commonest cyanotic congenital heart disease in children. So as we have known before, it includes 4 anomalies: the ventral septal defect, overriding of aorta, the right ventricular outflow tract obstruction, and right ventricular hypertrophy. So meanwhile, the TGA, it is the most common cause of cardiac cyanosis in the neonates. So it is more common in infants in diabetic mother, So TGA may be associated with genetic disorder and teratogens such as maternal diabetes, tortuous infection, ionizing radiation, and many more. So TGA is categorized into 4 main groups according to certain physiologic features, which depend on the presence of BSD and the pulmonary blood flow. So I think that one you can read it on your own. So in tricuspid atresia, so there is no outlet from the right atrium to the right ventricle. So there is a mandatory right to left shunt at the atrial level. So the presence and the size of VSD will determine the amount of blood flowing into the right ventricle. So if the ventricle septum is intact or the VSD is restrictive, is very small. So the right ventricle, the one below, will become completely hypoplastic and pulmonary atresia will be presented. So the degree of cyanosis will depend on the size of the VSD and the presence and the severity of any associated pulmonic stenosis. So in pulmonary vascular disorder, the one that have been that we have touched before, the PPHN, the persistent pulmonary hypertension. So it occurs primarily in term or late preterm infant, and it happened when pulmonary vascular resistance remains. So the next one is shock. We should not forget about shock as well. So shock can either be due to blood loss before or during labor, or it can either be due to severe intrauterine bacterial sepsis. Okay, next, other causes of cyanosis is methemoglobinemia. So it should always be considered when a patient presents with symptoms of cyanosis without presentation of respiratory or cardiac disease. So basically, methemoglobin is produced by the oxidation of ferrous iron into ferric iron in hemoglobin. So methemoglobin cannot transport oxygen. So patient is cyanosed, and they can have normal oxygen saturation on pulse oximetry. Why? Because pulse oximeter can only measure hemoglobin that is available for saturation. So next is acrocyanosis. Acrocyanosis is common in the delivery room, and it is usually normal. So it causes the blue color. This is the specific clinical features of acrocyanosis. It causes blue color of hand and feet, and the rest of the body will present pink color. So acrocyanosis is caused by vasospasm of the small vessel of the skin in response to cold. It can either be primary or secondary. So next is cold exposure. So this is very direct. Cold exposure, low temperature will cause a left shift of the oxygen dissociation curve. So it increased affinity for oxygen. So less oxygen will be delivered to the tissue. And the last one is polycythemia. This is condition where there's an increase of red blood cell. So increase in viscosity, when there is an increased red blood cell, there will be increase in viscosity of the blood, which eventually it will cause a sluggish blood flow. So this will increase the oxygen extraction to the peripheral tissue. Okay. So next, the clinical approach, which consists of history taking, physical examination, investigation, and management. Yes, doctor. Can I continue?
Nothing. Yeah, nothing. I was just changing devices. Okay.
Okay. All right. Okay. So we continue with history taking. So history is important as we want to classify in initial presentation, we want to classify it based on the age of onset. So usually the one who present very early in life would be more likely due to cardiac cause or neonatal sepsis. Meanwhile, the one presented much later, such as 3, 4, 5 years old later, they tend to be respiratory causes than cardiac cause. So as I have listed here, according to age, neonates, infants, toddler, older children, and old age group. So these are the specific DDX that we can think of. So the next history taking that we can, the next question that we can ask about the associated condition, for example, the fever. So fever will is associated with infection cause lah, or cyanosis. Okay, next. So for underlying medical condition, especially congenital heart disease, So it is important for us to ask for mother for the antenatal history. During antenatal period, is there any detailed scan that has already detected this congenital heart disease intrauterine? So we ask for family history of any congenital heart disease, and we should also ask for maternal illness, underlying maternal illness, diabetes, rubella, teratogenic medication, such as what I have mentioned before. TGA is associated with teratogens. So another one, during birth history, in birth history, we should ask for the perinatal problem. If patient is if baby is premature baby, or is there any eventful conditions such as mechanism aspiration, asphyxia. And then we should also ask for heart failure symptoms, poor feeding, reduced appetite tolerance, breathlessness, failure to thrive as well. And then any prior lung disease, asthma. So for asthma, it is important also to ask for family history of atopy. So in a case of neonatal sepsis, not to forget to ask for mother if mother has maternal GBS infection. Okay, next. So other history taking, we can ask for trauma, exposure to smoke or any chemicals, and then medication. So because blue skin color may occur in patient undergoing treatment with amiodarone. Okay, next we move on to physical examination. So in physical examination, if we're dealing with sinus child, it is important to take note of any dysmorphic features, as certain syndrome are associated with higher incidence of cardiac abnormality. For example, Down syndrome, DiGeorge, and Alagille syndrome. So in general examination also, we need to look for signs of cyanosis, the central and peripheral cyanosis, and also any peripheral vasoconstriction, for example, the cold extremity, and also clubbing. So vital sign is important, especially in the case of shock. Okay, next. Good. So Down syndrome. Okay, Down syndrome is the trisomy 21, and I bet all of you have already mastered the features of Down syndrome. So for example, the broad flat face, slanting eyes, epicantic fold, the single palmar crack crease, and all. So for DiGeorge, it is a condition that involves microdeletion in chromosome 22, and they may present it with small head, flat mid face, thin upper lip, underdeveloped jaw. And the easier way to remember the clinical features of DiGeorge is Catch-22. So as I have already included in the slide. Okay, next. Next is Alagille syndrome. Alagille syndrome is a genetic disease that is associated with pulmonary valve and pulmonary artery stenosis, liver disease, and hypercholesterolemia. So the clinical features will be prominent forehead, deep set eyes, pointed chin, and bulbous tip of nose. Okay. So the next systemic examination that we can look for is of course respiratory examination. So we must look for signs of respiratory distress, signs of upper airway obstruction, any lower airway disease, and signs of traumatic lung injury. So it is important to look in respiratory examination. So for cardiovascular examination, so tachycardia frequently accompanies cyanosis. However, if bradycardia present, it usually a bad sign of impending cardiorespiratory collapse. The next thing that we must look for is murmur. So because certain condition is associated with specific murmur. For example, TOF, it is an ejection systolic murmur at left sternal edge, and then TGA, it is a loud and single second heart sound. And then another signs we must look for is the heart failure signs. Okay, next, the investigation. So I divided into bedside, laboratory, and also imaging. So for bedside, we can put patient on pulse oximetry to measure oxygen saturation. Usually in cyanotic child, the oxygen saturation is less than 80%. So for ECG and echo, this is done to help in diagnosing congenital heart disease, if there's any suspected congenital heart disease. So for laboratory, ABG, we send to measure the partial pressure of oxygen. So if patient is, if there's a hypoxemia or normal, it could suggest different causes, different DDX. So FBC to measure hematocrit level in the case of polycythemia, and then met hemoglobin level. This is done in children with normal partial pressure of oxygen with exclusion when cardiac and pulmonary cause has already excluded. So the next one is hyperoxia test. So hyperoxia test is done to determine whether the cyanosis is due to cardiac cause or lung disease. So the child will be given 100% oxygen for 10 minutes. Then ABG will be sent to observe the partial pressure of oxygen. If it remains low, it is more likely of cardiac cause. But if it's significantly high, it suggests more on lung disease. So the next investigation is radiograph. So chest radiograph will help in determining any traumatic lung condition, intrinsic pulmonary condition, or even congenital heart disease. For example, TOF is we know the feature will be a boot heart shape. Okay. So for management, so basically the main in acute setting, we must resuscitate patient, secure airway, adequate ventilation, and circulatory support. So we must also correct the underlying emergency conditions such as metabolic acidosis, electrolyte derangement, hypoglycemia, and hypothermia. However, the goal of treatment is to treat the underlying condition that caused the cyanosis. For example, if respiratory cause, if patient presented with pneumothorax or hemothorax, so needle or tube thoracostomy will be given. If pneumonia, antibiotic, and if it is asthma, beta-2 agonist or steroid. If it is a cardiac cause, so early referral to cardiologist is important. And then if it is associated with duct-dependent lesion, IV prostaglandin E will be given to maintain the patency of the ductus atrosus until corrective surgery can be performed. So I think that is all from for my presentation.
Can we finish from the beginning?
Sorry, doctor, you are quite lagging.
Yeah, because I'm on the third. Can you show me the slide from the beginning?
Slide from the beginning.
The beginning. Yep. Cyanosis. Make sure you guys know the difference between peripheral cyanosis and can hear or not?
Tak jelas sangat. Still not clear, doctor.
How about now?
Okay. Okay, this one is okay.
Okay, anyway, cyanosis, make sure you guys know how to differentiate clinically when it's peripheral and when it's central, right? So peripheral is basically just the extremities, the fingers and the toes, right? Sometimes the lips looks a little bit bluish. Lips is not central unless it's also the tongue. So make sure you open up the mouth and look into the tongue. Okay, mucous membranes, not just the lips. Now next slide. Next slide. Okay, most of the causes is either respiratory or circulatory. It's either cardiac or respi. Now, the important thing if a child presents with cyanosis, if you could only make note of one that would make it to be cardiac cause, what do you think it is? Aisha, what's the screen? Oh, there. Which thing you look at? Cyanosis.
Pardon, doctor, can you repeat the question?
That would tell presentation will show you that it's more likely to be cardiac or if the child is a baby, is it more likely to be cardiac or ST usually?
Cardiac cause. If
Yeah,
if baby.
if it is a baby, generally speaking, neonates, if the child presents with cyanosis, usually it's caused by congenital heart disease. Okay, so most likely it's cardiac. Obviously, a big proportion of it is pneumonia and sepsis, right? But the older the child is, the less likely it's due to cardiac causes, unless the child has been known to have a previous congenital heart disease or cardiac problem, isn't it? Right?
Yes.
Okay. So that's the first thing, age. So based on history, the first thing you do is look at age. If it's a baby, newborn within a few weeks of life or a few days of life, then the higher differential diagnosis will be one with the cardiac causes, especially if the mother has been known to have gestational diabetes or has been known during antenatal follow-up to have something abnormal during the pregnancy. Okay. Obviously, things like GBS sepsis also can present with cyanosis, right? Pneumonia obviously also can present with cyanosis, but the younger they are, the likelihood of it being a cardiac problem is slightly higher, right? If the child is 9 years old, 7 years old, present with first episode of cyanosis associated with fever, all those stuff, obviously it's an infective cause, right? Could be pneumonia or could be a general sepsis secondary to any other infection, right? Usually, if it's in an older child, if it's secondary to cardiac causes, the child has been known to have a congenital heart disease or a rheumatic heart fever, right? So next slide. Next slide. Next slide. All right, so age. Okay, fine. Right. What's this other one? Your age. This is the history. The history bit. I shared the history bit. Yeah. Before that. Before that. Yeah. Even you can look by this list, right? Excuse me. You can look by this list, the causes based on age. It's more commonly cardiac causes, younger. As you grow older, it's usually infective causes or respiratory causes. So next. Right? If you think it's a congenital heart, then obviously maternal diabetes is important, right? Any evidence that would suggest a tortuous infection during antenatal period. GBS infection within the first early neonatal sepsis will first month of life next. Now, if you think it's a congenital heart problem and there is cardiac failure, so symptoms of heart failure includes poor feeding, right? So how would you ask for poor feeding, Aisha? Aisha, how would you ask for poor feeding?
Poor feeding, I will ask.
Okay, if it's a baby, how would you ask the mother about poor feeding? How does a baby feed?
Breast milk. Reduce breast milk feeding.
Sorry?
Reduce breast milk feeding or bottle feeding.
How would you ask for reduced breast milk or reduced bottle feeding? How would you ask for reduced breast milk feeding?
Ask for frequency of feeding.
Will the frequency increase or decrease if it's poor feeding? Think properly.
If it's poor feeding, it be more frequent because baby is still hungry. So
that's not at poor feeding. basically they will feed more frequently, but for what? Shorter periods of
Shorter period of time.
time. Yeah. So that shows increased effort,
Tolerate.
tolerance, right? So usually the child will suckle strongly for about 20 minutes on the breast. But now the child suckles for like 2 minutes and then gets tired. Then the feeding is interrupted. You have to stop for a while. The child breathes quickly for a while and then continues feeding again. So what you're actually asking for is interrupted feeding, right? So previously the child was able to feed like 15 minutes for 15 minutes fully, like strong sucks. But now the child only feeds like 1 or 2 minutes and then stops and then has to rest for a while. Looks like the child is breathing quickly and then continues feeding again, right? So now the total feeding time the child might be on the breast like for a total of 1 hour, but it's like intermittent sucking only. Okay, so that's breastfeeding. Bottle feeding, you could ask for what if it's bottle feeding? How long does the child take to finish the bottle? Am I losing you guys? Guys, can you hear me?
Yes, doctor. We can hear you.
So if it's bottle feeding, Ain Kalida, if it's bottle feeding, how would you ask for poor feeding? If the child is bottle feeding, baby is bottle feeding.
How long does it take to finish?
Okay. So if previously the child was only took 15 minutes to finish 2 ounces, and now has taken like 30 minutes to finish 2 ounces, right? So that's prolonged feeding, right? Also the amount lah, bottle feeding, you can easily see the amount of milk that is being taken. And then next slide. Next slide. Next. Physical examination, if it's a baby, make sure that you look for signs of dysmorphism. Anything under the sun. Okay. Next. 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 Okay, next presenter.
Everything going wrong today.
Itu juga.
Guys, you can start. Hi, who's the next presenter?
Ni doktor.
what's
Actually,
your-
technical problem. Sekejap,
Hmm.
Okay, very good morning to everyone. I'm Hazia Abdurrahim. So I'll be the next presenter who will be presenting about child who is presented with jaundice. So next. So this is my case scenario where there is a 3 weeks old female baby with no underlying medical illness presented with progressive yellowish discoloration of the skin for 2 weeks duration. So the important information over here is 3 weeks old baby, which is a neonate with no underlying medical illness with progressive jaundice for 2 weeks duration, which is we can consider as prolonged jaundice. Next. So basically jaundice means yellowish discoloration, either skin, mucous membrane, and sclera. So basically jaundice will be clinically detected. I mean clinically visible. We can see if bilirubin level is above 85 micromole per liter or 5 microgram per deciliter. So prolonged neonatal jaundice, we will say if let's say the child is presented with jaundice more than 2 weeks in a term baby or more than 3 weeks in a preterm baby. Next. So this is the bilirubin metabolism, which is important to know where we can identify where are the causes of the problem of jaundice. So basically, can you see? Boleh lah. So first, there will be production of bilirubin, where there will be reticular endothelial cell will destroy the old RBC and break down into heme and also globin. So this heme will be further break down into biliverdin and also iron, and biliverdin will be converted into bilirubin. So this bilirubin is unconjugated. So that one will be bind to albumin since it is non-water soluble. It will bind to albumin and reach the liver to be conjugated. So in the liver, it will be conjugate with glucuronic acid, the glucuronic transferase enzyme. Once conjugated, this one will be excreted into the colon via bile. So once it reached the colonic bacteria will unconjugate again this conjugated bilirubin and will be excreted. Will be unconjugated and will become urobilinogen.
So this urobilinogen normally will be 80% of this urobilinogen are usually oxidized by intestinal bacteria and converted to stercobilin and excreted into feces. However, 20% of this urobilinogen will be taken into bloodstream again as enterohepatic circulation, and some of them will reach the kidney and will be converted into urobilin and excreted into the urine. So the importance of knowing this bilirubin metabolism is basically classification. We go for classification, then we come over here. Classification first, next. So in terms of classification jaundice, we will divide into unconjugated hyperbilirubinemia or conjugated hypobilirubinemia. Either if patient presented with jaundice, we want to know either conjugated bilirubin is high or unconjugated bilirubin is high. So if let's say the unconjugated bilirubin is high, it means either there is an increased production of bilirubin, I mean either by hemolysis or anything, or there will be problem with conjugation. So basically unconjugated bilirubin will be divided into two, which is hemolysis and non-hemolysis. So hemolysis further divided into positive form and negative form. Positive form basically immune mediated, negative form is non-immune mediated. So under immune mediated, we have ABO-RH, resistance incompatibility, autoimmune hemolysis. And under negative form, which is non-immune mediated, we have G6PD, we have hemoglobinopathy, which is sickle cell, and also we have RBC membrane defect. So under non-hemolysis, we have Gilbert syndrome, which is problem with conjugation. We have physiological jaundice, which is most common causes of jaundice, prolonged jaundice in newborn. And also we have breast milk jaundice. So under conjugated hyperbilirubinemia is further divided into 6, whereas it can due to obstruction, can due to infection, can due to metabolic causes, toxic, autoimmune, and lastly can be due to idiopathic. Next. Since my patient presented with jaundice for 2 weeks duration, so the common causes of prolonged neonatal jaundice divided into 2, unconjugated and conjugated. For unconjugated, it can due to septicemia and urinary tract infection. So urinary tract infection basically can causes hemolysis. So breast milk jaundice, hypothyroidism under hemolysis can be due to G6PD deficiency or congenital spherocytosis. Galactosemia is unable to metabolize galactose in the milk, and Gilbert syndrome. So under conjugated hyperbilirubinemia, either can be due to biliary tree abnormality, either biliary atresia, choledochol cyst, Alagille syndrome, and also can be due to neonatal hepatitis, can be due to septicemia, urinary tract infection, and also can be congenital infection like torches. Metabolic disorder, we have citrine deficiency and also alpha-1 antitrypsin deficiency, and also patient under total parenteral nutrition also can have jaundice. Next. So if let's say a neonate presented with jaundice, the first thing we have to ask about the age of onset, either before 24 hours or after 24 hours. We should ask about duration of jaundice, the progression. I mean, first noted over the head, then after progress to the body, and then hand-wise. And then risk factor for severe neonatal jaundice, either prematurity or low birth weight, which can causes immature liver due to cannot metabolize the bilirubin. And then we have either patient presented with jaundice in first 24 hours of life, either mother with blood group O or rhesus negative, G6PD deficiency, any sepsis or any lactation failure, any cephalohematoma or bruises. Cephalohematoma causes blood accumulation in one place, so it can causes hemolysis, and then after that jaundice. Babies with diabetic mother, and also family history of severe neonatal jaundice in siblings. Birth history wise, ask about any infection during pregnancy, birth trauma, or any instrumental delivery. Next. So associated symptom wise, history. Regarding unconjugated hyperbilirubinemia, you should ask about anemic symptom. Is that the child appear pale or any difficulty in breathing? Normally in unconjugated hyperbilirubinemia, there will be normal color urine and also stool. And ask about family history of G6PD or any hemoglobinopathies. Ask about symptoms of acute bilirubin encephalopathy, especially drowsiness, sleepiness, either as poor feeding or any abnormality in cry pattern, especially high-pitched cry. For conjugated hyperbilirubinemia, normally presented with dark color urine, pale stool, pruritus, any bleeding tendencies, bruises, or family history of Alagille syndrome, and risk factor for neonatal hepatitis, which will be discussed in the next slide, further slide. For the family history, ask about the previous siblings with jaundice, previous siblings with kernicterus, and also neonatal death. Next. So in my patient, basically she was presented with jaundice started from 1 week of life, lasted for about 2 weeks, began to yellowing of her eyes and subsequent yellowing of her skin. She was initially diagnosed with physiological jaundice and associated with pale color stool and also dark color urine for 10 days duration. Otherwise, there is no abdominal distension, there is no pruritus, there is no easy bleeding or bruising. There is also no pale, no noted difficulty in breathing. There is no family history of G6PD, thalassemia, or sickle cell disease. Next. Birth history-wise, she was born full term via spontaneous vertex delivery. Birth weight 2.9 kilogram. Otherwise, there is no trauma instrumental delivery. There is no complication at birth or at nursery or discharge home. Patient was jaundice. The patient was not jaundice at discharge. Her blood group was her blood group is A positive. Feeding wise history, she was breastfed exclusively up until now. After persistent jaundice for 5 days, a mother noticed that there is a reduced feeding 5 to 7 times per day. Current weight about 2.6 kilogram, and family history wise, there is a previous history of siblings with jaundice. Next. So based on my history, most likely my patient has conjugated hyperbilirubinemia. So the most common causes of so the differential diagnosis wise for conjugated hyperbilirubinemia is one is neonatal hepatitis, where it can be due to infectious causes, can be due to autoimmune causes, or after we rule out these things, we can say this is idiopathic neonatal hepatitis. So infectious causes wise, you can ask about patient has fever or not, and then risk factor for hepatitis B and also C, either any blood transfusion, mother with Hep B or Hep C infection, any injectable drug use in 3 weeks time. Risk factors for torture are about any rashes, exposure to the cats, any history of fetal growth restriction during pregnancy, and also history of chorioamnionitis during pregnancy. In terms of metabolic causes, for alpha-1 antitrypsin deficiency is about poor feeding and also growth for the older children actually. And then ask about the family history. For Alagille syndrome, ask about any dysmorphic features and also family history. Next. So these are the physical examination. First, we have to look for general. In my patient, she was alert, conscious, jaundice over the cephalic and also truncal area with scleral icterus. Otherwise, there is no dysmorphic features, there is no conjunctival pallor. So these are the pictures showing jaundice. And pictures over the right side, it shows Kramer's rule. Basically, a visual assessment we do in children to find out the level of bilirubin. I mean, if let's say the jaundice is only over the head and also the neck area, the most likely the range of bilirubin is around 66 to 133. If let's say upper trunk, most likely is 85 to 204. So it just to predict the extent and severity of jaundice. Next. So the dysmorphic features we most likely to look for is Alagille syndrome, where patient will be presented with prominent forehead, deep set eyes, pointed chin, and also bulbous tip of nose. So stool color in my patient, there is a presence of pale stool. So below pictures, the upper one shows the healthy stool. The lower one is suspect is unhealthy stool, most likely pathological. So in my patient, there is a pale stool. So for abdominal examination, in my patient, it was not distended. There was no scar. Liver was palpable 1 finger breadth below costal margin with nodular surface. Otherwise, there is no splenomegaly or ascites. If let's say neonate presented with jaundice, one of the things that we have to look for during examination is sign of acute bilirubin encephalopathy. So these are the signs. Basically, we use bind score. So under bind score, we have three. We have mental status, we have muscle tone, and also cry pattern. So under mental status, see whether patient is sleepy, baby is sleepy or lethargy, any poor feeding. Under muscle tone, look for any hypotonia. Under cry pattern, Observe for any change in cry pattern, especially high-pitched cry, or patient is difficult to console, or inconsolable crying. So in my patient, there is a decrease in feeding. So the score will be 1, which is score 1 to 3 shows mild acute bilirubin encephalopathy. So next. So investigation wise, to proceed, first we proceed with serum bilirubin to look for total serum bilirubin level, the direct and indirect bilirubin. Then full blood count to look for hemoglobin level and also reticulocyte count. Full blood picture to look for any hemoglobinopathies. Liver function test, basically we look for transaminitis. We look for ALT, AST. If ALP, GGT elevated, most likely there is an obstruction. Coagulation profile, look for any coagulopathy. Urine dipstick and microscopy, basically to look for, starting from here, we want to look for the causes of jaundice. So urine dipstick to look for presence of bilirubin. If let's say there is a conjugated bilirubin, most likely there is a presence of bilirubin in the urine. And then we look for UTI. For virology wise, look for torture screening and also hepatitis B and also hepatitis C screening. And then for autoimmune causes of hepatitis, look for autoantibody screening, presence of ANA. Asthma is anti-smooth muscle antibody. Anti-LKM is anti-liver kidney macrosomal antibody. And then for metabolic causes, look for a level of alpha-1 antitrypsin and also serum citrulline level. For genetic studies, for Alagille syndrome, look for JET1 gene mutation. For ultrasound and hepatobiliary system, basically to differentiate whether there is an obstructive or non-obstructive causes. For obstructive causes, basically in patients with neonatal jaundice, prolonged neonatal jaundice, one of the things that we have to rule out is biliary atresia, especially in conjugated hyperbilirubinemia. So for confirm the diagnosis, we have to do hepatobiliary scintigraphy, HIDA scan, to look for any biliary tract obstruction. Next. So these are the investigation results in my patient. So serum bilirubin wise, there is elevated in total serum bilirubin and also direct bilirubin. And then the liver function test shows ALP and also GGT elevated. For ultrasound hepatobiliary system, there is a contracted gallbladder with dilated intrahepatic duct. For HIDA scan, shows normal uptake by liver, but there is no excretion of isotope in the bowel even after 24 hours. So HIDA scan normal in a normal child, there will be normal uptake by the liver and there will be excretion of the isotope into the bowel. Shows there is no obstruction. If there is no excretion into the bowel, means there is an obstruction in biliary tree. For virus screening wise, there is all negative. Next. So most likely, the causes of neonatal jaundice in my patient is biliary atresia, since there is an obstruction in biliary tree. So management of prolonged neonatal jaundice wise, first we have to do a risk stratification of the child. This stratification mainly important to whether we want to treat the patient as outpatient or inpatient, whether we want to refer the patient or not. So based on this risk stratification, my patient has moderate risk as she was presented with conjugated hyperbilirubinemia, with pales too, dark color urine, poor weight gain with hepatomegaly. So most likely my patient require referral to pediatric team. And also further, we have to proceed with workup for conjugated hyperbilirubinemia and treat according to the causes. So, next. So management of biliary atresia mainly, there is no pharmacological management, mostly surgical, where we have to confirm the diagnosis via intraoperative cholangiography to assess the patency of biliary system. And then we proceed with Kasai procedure. Kasai procedure basically Roxanne Y hepatoportoenterostomy. It means we will connect the jejunum to the liver so that there will be biliary drainage. If let's say we diagnose biliary atresia lately up until it turns out to be cirrhosis or what, we have to do liver transplantation. Or if let's say there is Kasai procedure failure, we have to proceed with liver transplantation. I think that's all.
Okay, Hazia, what's the most important thing in approaching a child with jaundice?
We want to find out the causes and also severity.
So what's the most important thing
Ask about
in finding out the causes?
treatment wise.
No, what's the how do you find out the causes? What's the most important thing to figure out in the first place when a child is jaundice? What's the first thing you need to figure out?
Is there any encephalopathy?
No. I'm not talking in terms of severity. I'm talking in terms of figuring out the diagnosis. But then your child is there. What's the most first thing that you should figure out?
Is there any biliary atresia or not?
No, you're talking about neonatal jaundice, which the title of your presentation is actually just jaundice, not neonatal jaundice. But because you have chosen a case in which biliary atresia is the diagnosis, I let the presentation flow in that manner. But what's the most important thing in determining the cause of the jaundice? Your chart is already giving you the answer. What's the most important thing to approach a child with jaundice? To determine in approaching a child with jaundice?
Either it's unconjugated or conjugated.
Yes, whether it's conjugated or unconjugated. What's the history that you should take to determine whether it's conjugated, to give you an idea whether it's conjugated or unconjugated?
Symptom wise, ask about pale stool, dark urine in conjugated.
So that's the first thing you should ask, isn't it? Whether the child has pale stools and dark urine, isn't it? If the child has pale stools and dark urine, most likely it's a conjugated hyperbilirubinemia. In a 5-year-old child who presents with jaundice, what are the likely causes, Hazia?
You can still divide it into unconjugated and conjugated. If unconjugated, we can hemolysis, either thalassemia or G6PD. If conjugated, we can divide
Hazia? Hello. Hello. Can you ask Hazia to repeat again? Is she gone? Or is it my connection?
Dia disconnected.
She disconnected. It's not me, right? Okay, so jaundice, the first thing is you need to decide whether it's conjugated or unconjugated. Can you guys hear me?
yes, Dr. Sir.
Yeah,
Yes,
because
yes.
my Wi-Fi, the connection at my place is also a bit off today. Now, if it's jaundice, the first thing you guys should decide is whether it's conjugated or unconjugated. If it's a neonatal jaundice, it's even more important because if it's biliary atresia, the earlier you do the Kasai procedure, the higher the likelihood of success. The later you do it, the likelihood of being unsuccessful is very much higher. So ideally do it before 6 weeks, isn't it? Right? Okay, so that's neonatal. If in the neonatal period, it's very, very important to make sure that it's not biliary atresia because it's time dependent. Okay, the success of the procedure it's time dependent. The later the Kasai procedure is done, the higher the likelihood of it being a failure and the child going to liver failure later on and requiring liver transplant. Now, in an older child, usually the causes tend to be secondary due to either hemolysis or hepatitis. So usually it's unconjugated in an older child. Okay, not always, but most of the time lah. So in an older child, 5-year-old, 6-year-old, suddenly came in jaundice and pale. Usually it's due to an infection, whether it's hepatitis A, hepatitis C, or something like any viral infection that can cause a hepatitis. Dengue can do it, malaria can do it, right? Or a secondary to hemolysis, T6PD deficient child. Okay. Okay, so once again, causes, the more frequent causes change with age group. In a neonate, you must make sure that it's not biliary atresia. That's the most important thing. Okay. Okay. Next presentation. Any questions? Not. No questions. And next presentation.
Morning, my friends and also Dr. Chan. So next we proceed with the presentation of child who is pale. So pale and so any condition that decreases the hemoglobin concentration or alters the blood away from the body surface, it can present as pallor. So pallor is the common presentation of anemia, and anemia, it can be defined as the hemoglobin levels that is below the normal range. So here I attach the hemoglobin levels according to the age from the PITS protocol. Okay, next. So how we classify the anemia? So first is based on the etiologic or the causes of the anemia, which can be divided into 3 main causes, which are impaired red cell production, increased red cell destructions, or there's a blood loss. So in impaired red cell production, either due to ineffective erythropoiesis or red cells aplasia, which is there's a complete absence of the red cell production. In the hemolysis, it can be further divided into red cell membrane disorder or enzyme disorder or hemoglobinopathies and also immune causes. So usually patient with hemolysis can develop anemia when our body cannot compensate with the hemolysis. And other causes are the blood loss, which can occur in fetal maternal bleeding or chronic GI blood loss, for example, in Meckel's diverticulum, or inherited bleeding disorders, for example, in the von Willebrand disease. Okay, next. So anemia can also be classified according to the morphologic classification based on the red blood cells indices, which are from the mean corpuscular volume and also mean corpuscular hemoglobin. So it divided into the hypochromic microcytic, which consists of iron deficiency anemia, thalassemia, chronic disease, sideroblastic anemia, and also lead poisoning. Or it can be due to macrocytic anemia, which usually caused by megaloblastic anemia in vitamin B12 and also folate deficiency. Or other classification is normal MCV and MCH, or we call it normochromic normocytic, which can occur in hemolytic anemia, chronic disease anemia, and also bone marrow failure. Other causes such as hematological malignancy and also renal failure. Okay, next. So how we approach the children with anemia. So this is from the PITS protocol. So of course, first we need to ask about the history, and then we go to the physical examination, and then the basic or preliminary investigation of the hemoglobin and other red blood cells indices such as hematocrit, MCV, MCH, and also if we need for the investigation, blood films and reticulocyte count. So in PITS protocol, it divided into whether patient have hepatosplenomegaly or not. If patient have hepatosplenomegaly, then our differential diagnosis will be more due to malignancy or chronic hemolytic anemia, or there's a chronic infection. But if there is absence, or it could be due to acute blood loss or acquired causes such as iron deficiency anemia or acute hemolysis and others as stated in the diagram. Okay, so next, we go to the case discussion. Okay, first, we have trigger 1. So 22 months old Malay boy. He was brought by his mother to the ED with complaint of pale skin. So question 1 is, what are the further history that we would like to ask? So before we go to the question, we look at into the important points. So first, the chief complaint is the pale skin, which is a common manifestation of the anemia. So the causes has been listed before. The other important points are the age of the patient. So this patient is 22 months, which is in the toddler age. So certain age groups have their on common causes of anemia. For example, in neonates and young infant, it can be due to blood loss, such as in the intrauterine blood loss, such as in placental eruption or subgaleal hemorrhage, or due to immune hemolytic anemia, congenital infections such as parvovirus B19, congenital hemolytic anemia in hereditary spherocytosis or GCSPD, and also anemia of the prematurity. In anemia of prematurity, actually the preterm infant has lower hematocrit and also hemoglobin, and also have shorter red blood cell lifespan compared to the term infant. So their decline in RBC production is occur earlier after they are born, and so will be much more severe. And actually, I forgot to include here, but the most common cause of anemia in young infant is actually the physiologic anemia, which occur at 6 to 9 weeks of age. This is because there's an increase in erythropoiesis and also reduced production of erythropoietin. Okay, so in infants 3 to 6 month age, the most common causes is hemoglobinopathy, and in toddlers, children and adolescents, such as in this patient, the more common causes is the acquired causes such as iron deficiency anemia. So the inadequate intake of iron is common in infant because they need iron, additional iron is required because there's an increase in blood volume that is accompanied with their growth, and also they want to build the iron store in the child. Okay, next. Other important points in the trigger one is patient is male patient. So some inherited causes are X-linked, for example, G6PD deficiency and also X-linked sideroblastic anemia. And other points is that patient is Malay. So thalassemia is common in the Mediterranean and also Southeast Asian descent. Okay, next. So we go to the further history. What are the further history that we want to ask? First is the onset. It is important because the acute onset of pallor is usually consistent with life-threatening causes or life-threatening hemolytic event. For example, in the hypovolemic shock, for example, if patient have massive hemorrhage, so we need to ask about the history of traumatic event, or even in the autoimmune hemolytic anemia, it can present with severe anemia. And other causes such as sickle cell disease with splenic sequestration, it can present with acute presentation of severe anemia. And then we asked about the other symptoms of anemia, such as fatigue, poor exercise tolerance in this patient, poor feeding, any irritability, or breathlessness, or pica, which is the compulsive eating of non-nutritive substances. And then for the differential diagnosis, we need to ask about the hemolysis, where the patient have any yellowish discoloration or changes in the urine color, which could point to the hemolytic causes of the anemia. And then ask about if a patient any symptoms of bleeding, such as blood in the stool, any episode of trauma, prolonged bleeding from trivial wounds, or oral cavity bleeding and nose bleeding, which can point to the blood loss as the causes of the anemia. And then also ask about symptoms of malabsorption, such as diarrhea, and also oily, full-smelling stool or abdominal distension. As we know, the iron deficiency anemia, one of the causes is the malabsorption. Okay, so ask also about the history related to worm infestation. For example, if patient have frequent barefoot when playing outside, which could expose patient to hookworm infestation, and symptoms such as skin rash, itchiness, abdominal pain, and also diarrhea. Okay, next. And also ask about if whether patient has unsteady gait and also history of falling. This is due to vitamin B12 deficiency, because vitamin B12 deficiency can cause peripheral neuropathy. So ask about the unsteady gait. And then whether patient have recurrent infection or bruises, which could say that there's an involvement of other cell lineage, for example, pancytopenia, which could lead to other differential diagnosis. And then other history that we could ask is the history of any traveling to area that is high endemic in malaria, which also can cause anemia. And important thing is to ask about the nutritional history, age of weaning. Because IDA, eye deficiency anemia, it can develop when patient has delay in the introductions of weaning. And also ask about the daily meals, what type of diet patient had in a day, and if patient had milk, not breastfeed, and ask about type of milk, whether it's cow's milk or goat's milk, because it can lead to different type of anemia, and also the amount of the milk. And also ask about the breastfeeding history, whether patient still breastfeed, because patient who are still breastfeed after exclusive breastfeed after 6 months, and also and mother is a strict vegetarian, it could lead to vitamin B12 deficiency. Okay, next also ask about the birth history, the gestational age, duration of birth, hospitalization, and if there is a presence of history of hyperbilirubinemia in the newborn, it can suggest a hemolytic etiology of the anemia. Okay, next. If for the past medical history, we could ask if patient had previous history of the same presentation or previous history of the anemia, we could suggest an inherited disorder. Or next, ask about the drug and toxin exposure, which are listed in the pictures. And these drugs is actually it can cause anemia in patient with underlying G6PD. And ask about the developmental history, whether there's a developmental delay. They can also be associated with iron deficiency anemia, vitamin B12 and folic acid deficiency. And ask about the family history, any family history of anemia, and family any family members that undergoes cholecystectomy or splenectomy, which could suggest that patient has an inherited hemolytic disorder in the family. Okay, next. Next. So after upon history taking, this is trigger 2, the skin changes actually only be noticed by relative who has not seen the child for 5 months, but the mother still brought him to the ED, even though she actually doesn't notice any changes. And upon review of the symptoms, patient is active. And other point that I would like to say here is the patient like to play outside barefoot. And another important point is patient is actually a picky eater, a small amount of chicken, fish, and some vegetables, and he loves to drink milk, which drinks 6 to 8 bottles of whole milk daily, which is actually excessive. And other history was unremarkable. So the important points here that I would like to highlight is that the skin changes is only noticed by the relative who has not seen the child. This indicate that there's a slow development of the palate. And then also there's a picky eater and also excessive intake of a whole milk. Whole milk is actually a cow's milk. So excessive ingestion of cow's milk is not good, because first, cow's milk they are directly toxic to the intestinal mucosa, so it can cause microscopic bleeding. Secondly, cow's milk, it has low iron bioavailability, so low iron will be absorbed. And thirdly, cow's milk usually have high fat content. So when patient have excessive cow's milk, they don't want to eat other food because they already they already have high fat content in the cow's milk. They already feel full with the intake of the milk. Okay, next. So question 2, what are the physical examination and its expected finding? So in general, generally we can see the patient statue, whether the patient has small statue, such as in which can occur in Fanconi anemia, or patient who is malnutrition, and look if patient irritate or not, irritability or not, if patient is active or look tired. And also observe the skin changes where the patient has pallor or jaundice. Beside pallor or jaundice, we can observe also other skin changes, such as in figure 2, you can see there's a hyperpigmentation, which usually occur in Fanconi anemia. And also if patient have petechiae and purpura, such as in autoimmune hemolytic anemia with thrombocytopenia, or even in bone marrow aplasia. Okay. And then peripheral examination, we look at the colonochia, spoon-shaped nail, which is the manifestation of IDA, or triphalangeal thumb. Triphalangeal thumb is the in which our thumb and their thumb has 3 phalanges, which is the manifestations of diamond black fan anemia. And then also is there's a hypoplasia of transaminase in Fanconi anemia, and also if there's any presence of Mills line, which indicate heavy metal ingestion, or sickle cell anemia can also have Mills line. And don't forget to take the vital sign, especially the heart rate, blood pressure, semua lah penting, all important, temperature and also respiratory rate. And took the measure the weight and also height for the anthropometric measurement. Okay, next. So on face examination, we can see there's a congenital papilla or scleral jaundice. Observe there's a thalassemia facies and also microphthalmia, which is as you can see in the figure 7, the right eye. The right eye is abnormally smaller, which can occur in Fanconi anemia. So other findings are the glossitis or angular stomatitis that can occur in iron deficiency anemia. Okay, next. For the chest examination, also we need to look for if there's any shield chest or widespread nipples, such as that occur in the diamond black fan anemia, or there's a systolic phenomena as the consequences or complications of the chronic anemia itself. And then on the abdominal examination, examine if there's presence of the hepatosplenomegaly, which could lead to differential diagnosis. And also don't forget to do the parietal examination to look for the color of the stones. And then figure 12 here, I put is the features of the diamond black fan anemia, which is the anemia that falls under the red cell aplasia. It's actually a rare inherited blood disorder that affect the ability of the bone marrow to produce red blood cells. Okay, next. So on this patient, figure 3, upon examination, all the vital signs are normal. Patient height and weight is according to the centile, but patient looks pale. And another important point is patient is tearing and eating paper from your exam table. So this indicates patient has pica. So other findings, patient have pale conjunctiva. And on exam auscultation of the heart, there's a grade 2 systolic ejection murmur. So from this case, I think this systolic ejection murmur, it can be innocent injection murmur that is caused by the increased blood velocity due to underlying anemia in this patient. Okay, other finding are unremarkable. Okay, so next. So after the history and physical examination, so what are our professional right now is the iron deficiency anemia due to inadequate intake of iron. Is because first patient have excessive amount of cow's milk, which has low iron bioavailability, and the patient also did not take enough iron rich food. So other differential diagnosis that I put here is iron deficiency anemia secondary to chronic blood loss. This is because of the effect of the toxic in the cow's milk to the intestinal mucosa, which can cause a microscopic bleeding. And other causes, other deficient I put here is the vitamin B12 or a folate deficiency, because patient had small amount of chicken, fish, and some vegetables, but patient doesn't have other manifestations such as bruises, infection, or peripheral neuropathy. And then other deficient I put here is the IDA secondary to the worm infestation, because patient has history of like to play outside with barefoot. However, there was no other symptoms such as diarrhea or skin rash or fever. And last differential diagnosis is thalassemia carrier, is because here patient have mild anemia, and there's no history that could suggest family history of the thalassemia. Okay, so next. So question 4, the investigation to confirm the diagnosis. And of course, the important one is the full blood count. We need to look the hemoglobin, hematocrit level, which expected to be low. So and also the MCV and MCH, because our provisional now is IDA, so we expected it to be also low. So RDW, red cell distribution weight, expected to be high. And also we can calculate the Menzel index, which is MCV divided by RBC, which could differentiate between the IDA and also thalassemia. Other investigation is the reticulocyte counts, and also we need to look at the other cell lineage, white blood cells, and also platelet. Okay, next. Next investigation is the full blood film. So as you can see in the figure 13, this is a blood smear from the patient with iron deficiency anemia. As you can see, there's a hypochromic and microcytic red blood cells, and also there's the presence of pencil shaped cells. Next is figure 14. You can see there's a blood smear from megaloblastic anemia, which can occur in vitamin B12 deficiency or folate deficiency. There's hypersegmented neutrophils, and also macroovalocyte. So other findings, ada basophilic stippling, which can occur in thalassemia, also can occur in megaloblastic anemia. So other blood film that I included here, although it is not one of our differential diagnosis, but I just want to include here is the figures of the blood film findings in the G6PD, which you can see there's a blister cells. Okay, next. So figure 17 here, I showed there's a presence of spirocyte, which can occur in hereditary spirocytosis or autoimmune hemolytic anemia. And figure 18, you can see there's a presence of sickle cells. Okay, next. Okay, so in this patient, it is important to do the iron profile because we suspect patient have iron deficiency anemia. So in iron profile, there's a serum iron expected to be low, serum ferritin also reduced, total iron binding capacity we expected to be increases, and transvenous saturation is expected to be decreases. And next, we do also stool for occult blood and also stool examination for AIDS, since our differential diagnosis is the chronic blood loss and also womb infestation. Okay, next. Okay, so trigger 4, the investigation reveals that patient have low hemoglobin, hematocrit, MCV, and RBC. So this is a microcytic anemia. Patient also have a high red cell distribution weight with normal reticulocyte count and normal white blood cell and platelet. So in the iron profile, we can see there's a decrease in iron and ferritin level and increase in the TIBC levels. So the lab reports of the blood film come out to the result is microcytosis, hypochromia, mild anocytosis, and polychromasia. So this from this investigation, we can say that the patient have iron deficiency anemia. Okay, next. So what are the management? So in this patient, is usually involve the dietary advice and also supplementation with the oral iron. So in otherwise healthy patient, we can do a therapeutic trial of oral iron. It's the best diagnosis study for iron deficiency. So based on I found in the illustrated textbook, in our textbook, the recommended, the best tolerated preparation is the sodium iron editate or citron or Niferec. So the usual therapeutic dose is 4 to 6 milligram per day of elemental iron. And if patient is compliant with the iron, the HB can be raised about 10 gram per liter per week. And also we need to advise patient when they took this oral iron, they need to take maybe with orange juice to increase the absorption, and then took the iron, oral iron in between the meals or when the stomach is empty, and avoid taking it with the dairy product because it's interfere with the absorptions of the iron. And also for the dietary advice, we need to limit the cow's milk to not more than 20 ounces or 600 ml daily, and then encourage at least 3 servings of the iron rich foods in this patient. Okay, next. How about blood transfusion? This is not required in this patient unless patient already have overt cardiac decomposition, for example, heart failure, or patient is severely symptomatic, already have a failure to thrive or poor weight gain. And important thing also, we need to follow up this patient because we want to assess patient's response to the oral iron therapy. So this patient has a mild to moderate anemia. So we follow up patient within 7 to 10 days after we initiate the treatment. So during the follow up, we take the blood investigation to review the hemoglobin levels, and also need to do assessment of the if patient still has pale skin, and also physical examination assessment if patients still have conjunctival pallor or systolic ejection movement that I mentioned just now. Okay, that's all.
Any questions? Not.
Tak ada.
Any questions? No. No, then next presenter, please.
Oh, by the way, if you are supplementing with iron, right, 10 days, you won't actually see a change yet. Because how long does your red blood cells take to cycle?
120
3
days lifespan.
Yeah, 120 days, isn't it, right? So within, I think sometimes when you follow up you said what, 10 days, is it? You said 10 days, right? If you follow up in 10 days, it's more like checking of compliance, whether the child developed iron, whether the child developed constipation with the supplementation or not, isn't it? But actually, it takes at least 2 to 3 weeks to see it could rise up slightly. Usually, if you want to repeat blood, you take in 3 months' time, isn't it? Because that's physiology, isn't it? Your RBCs, the cycle of your RBC is about 130 days. Okay. But important thing is to make sure that it's actually iron deficiency. And remember, iron deficiency, and it's not more serious things, which would be like thalassemia, or the even more serious things would be leukemia, right? So if a child is having anemia, first things first is whether you need to decide whether it's an acute thing or a chronic thing, right? If the child looks acute, the parents notice that the child looks acutely pale, associated with easy bleeding tendencies, right? Associated with lethargy, poor feeding, then you're going to think more in terms of leukemia, because that's a more important thing not to miss, isn't it, right? Also in pediatric population, thalassemia, isn't it? But thalassemia, the parents would notice it over a period of time rather than acutely, right? Also in thalassemia, they tend to be hepatosplenomegalosis, so sometimes it's associated abdominal distension, right? Okay. Next, child having shortness of breath.
Okay. Right, good morning. So I'm going to proceed with a push to the child having a shortness of breath. Okay, next. So here is the content of my presentation. Next. Okay, so shortness of breath, according to Telly O'Connor, it's defined as an unexpected weakness of the breathing. And according to the up-to-date, it also known as a term as dyspnea. It is characterized by there is a subjective experience of the breathing discomfort of the patient, which can be vary in intensity from person to person. And the onset we could be acute and chronic. So usually for acute cases, it's till days presentation, and chronic more than weeks. And next. All right, so here is the causes of the shortness of breath, divide into infant, toddlers, and also older children. So basically in infant can be bronchiolitis, pneumonia. Pneumonia can be in any age, foreign body, when the child started to mouthing, viral induced waste, and congenital heart disease. Toddlers and also older age children more or less are the same causes, bronchiolitis, pneumonia, acute epiglottitis, viral group, foreign body. And next. Okay, what are the history that we need to ask? First, the presenting illness, ask about the onset, whether it is sudden or gradual, the duration itself, when it occur, whether it is the shortness of breath at rest or during activities, or does it worsen at day or night? We might think of the clue of the differential, and what are the precipitating factors that cause the shortness of breath, that for example, like could be allergen, dust, smoke exposure, or maybe this patient have a respiratory infection, or food, maybe have an allergy, or foreign body. And what are the relieving factors of the condition, and recent travel history. And we also need to ask about the associated symptoms, like cough, or the nature of the cough, whether it is a barking cough, or whooping cough. So any fevers, does it the fever associated with cheese and rago, and then whether this the shortness of breath involving the heart, asking about the chest pain, the noisy breathing like wheezing or stridor. And then this patient also come with pale or bluish discoloration, any others respiratory distress symptoms like drooling of saliva, any change of the voice, hoarseness and muffled voice, and reduced activity and lethargy. So next, I will further explain according to the differential. So if in case of acute bronchiolitis commonly in toddlers less than 2 years, so need to know that the risk factor of it, a preterm infant or those with underlying congenital heart disease. So usually they presented with history of low-grade fever, mild coryza and cough, and followed by the shortness of breath and also wheezing. So in case of pneumonia, usually patient they come with a high-grade fever which preceded by history of coryza symptom and also upper respiratory infection. They also have wheezing, and in case of pneumonia, they have you can see that the patient, the children are look irritable, ill-looking. Maybe ask about the history of sick contact, and in severe cases, the child are having a poor feeding and drowsiness. And in case of bronchial asthma, usually in older children, the important history, you need to ask whether the patient having a recurrent shortness of breath and wheezing, chest tightness, and if patient having cough, does it persistent and does it worsen at night, and does patient having a reduced activity. And also you need to ask more about the history, like personal history of atopy and also the family history of asthma or atopy that can give a hint to the diagnosis. And does it relieved by the bronchodilator, and what are the triggering factors at the time and previously. Next, the others like foreign body, which common in also in toddlers. So what are the hints that a patient come with persistent wheezing which is unresponsive to the bronchodilator, and also when the children when the child having a unexplained chronic cough with a respiratory distress symptom like drooling of saliva, having a noisy breathing like stridor, and also ask about whether the patient having a history of choking with or the mother or the caretaker could witness the aspiration of the patient are playing with the toys. So for other than the foreign body, we also about the croup and also acute epiglottitis. So in case of croup, patient usually have a low-grade fever and coryza symptoms and a very having a cough, which is a nature like barking cough, stridor, and hoarseness of voice. While in case of acute epiglottitis, we need to ask like patient are having high-grade fever, which can preceded by the upper respiratory infection. Patient also present like lethargy and having a poor feeding. In case of that, patient also have a dysphagia, either respiratory distress symptoms like drooling of saliva. The patient will look very ill-looking, having a muffled voice, and also need to ask about the immunization history up to his age, including like pneumococcal, HIV, DTAP. Okay. Next. So other than that, need to rule out the cardiac causes. So the presentation would be different in case of infant. They are more commonly to present like breathlessness, having a sweating, poor feeding, failure to thrive, lethargy, and recurrent chest infection. While in case of older children, they are more likely to present with a chest pain, palpitation, orthopnea, and also exercise intolerant. And we also need to exclude anaphylaxis, like asking the patient if come with shortness of breath, does it having a rash, any facial edema, any history of vomiting, any history of known case of allergy, and does patient have altered consciousness. Okay, next. So what are the other history that we need to ask? So other than that, history of presenting illness, we need also to dig on the past medical history. Does a patient have a asthma, underlying congenital cardiac disease, or cystic fibrosis? The previous history or surgical history, the previous or recent hospitalization, because it is important what the recent hospitalization, what are the diagnoses, what are treatment given, because maybe patient can be partially treated before. Okay, next, immunization status. You need to ask up to the child age, not only the HIV, the pneumococcal vaccine, and DTaP. And then ask about the birth history, antenatal scan, whether there's abnormality during the antenatal scan, or does patient delivered premature, or does during delivery had a complication like meconium aspiration that can lead to the lung infection. And then other than that, also need to ask about the nutritional history like diet and also allergy to throw out any allergy. And then we also need to ask about the family history of congenital cardiac disease, asthma, and atopy, as I said before, and also the social history, also important to ask about the smoking exposure, the education of the parents, the home environment, does it close to the factory, and does it close to the hospital, can they reach within the time. Okay, next. Okay, so what are the physical examination that need to be seen? So we can assess the examine the patient generally and also systemically. So for general assessment, so first look at the appearance of the child. What the patient look restlessness, very ill looking. Does it agitated? Does it having pallor, periphery, or and cyanosis? You can see but for sinus, you need to see whether it's peripherally or concentrally, and then look for the consciousness level, a respiratory rate, count for the respiratory rate, and look for the position of the patient. Sometimes the child look in tripod position, like in the picture, tripod position, where they are trying to get more air, and look for the signs of other signs of respiratory distress like chest varization. You can see in the picture, this chest varization, the use of the accessory muscles. Does it there has nasal flaring, any cyanosis, any noisy breathing like stridor or wheezing. So other than that, also need to look for the vital signs. Check for the temperature, whether the patient is febrile or afebrile, and a respiratory rate, pulse oximetry. Since patients are coming with shortness of breath, need to know the pulse, take the pulse oximetry, the BP, the heart rate, and also the anthropometric of the child. Okay, what are the systemic examination? Next. Okay, first, for respiratory examination, do inspection like check for any chest deformity, any scar, check for palpation, whether there is reduced chest expansion, any tracheal deviation, any dullness, which can, we think of consolidation, hyperresonance. And for auscultation, we need to hear for any air entry, whether there is reduced bilaterally or unilaterally, there is abnormal breathing like bronchial breathing, that might be clue for the pneumonia, any additional sound like crepitation, also clue for the pneumonia, and other additional sounds like rhonchi or prolonged expiratory periods that might be clue for the asthma. So other than respiratory examination, we also need to do for CVS, cardiovascular examination to rule out for the cardiac causes. We expect to see displaced apex peak, any jugular vein distended or any murmur, and last, central nervous system, check for the altered mental status. Okay. Next, here is the summary if patient come with dyspnea, and also after we examine the patient. So in case of shortness of breath with stridor, what are the possible diagnoses? So in case of dyspnea and wheezing or crackles, decreased air entry and pneumopneumonia, this can be, you can look later. Okay, next. So what investigation that can be done in case a patient comes with a shortness of breath? First, we can do easy bedside. I divide into bedside, blood investigation, and also imaging. In case of bedside, we can do ECG, look for the heart rate, the rhythm, the axis deviation. Second, look for do a spirometry to differentiate whether it is obstructive lung disease or restrictive lung disease. And then for blood investigation, of course, we send for full blood count. Of course, we want to rule out for anemia. And then in case we are thinking of infection, we expect to have leukocytosis or neutrophilia. So in case of viral infection, severe viral patient can have a leukopenia or lymphocytosis. And other than full blood count, also we need to send for renal profile to look for any electrolyte imbalance, arterial blood group gases, to look for the oxygen, and then look for respiratory failure or any metabolic acidosis. So in case of patient with suspected infection, so we send for blood culture and sensitivity to know the causative organism. And then other than that, we also can send for imaging. So first thing, we send for chest x-ray to look for the cardiac cause, cardiomegaly, or the respiratory. Look for, in case of pneumonia, we expect that there is a consolidation airborne program. So in case of acute epiglottitis, you expect to see thumb sign, steeple sign is a group, and hyperinflated lung in case of acute bronchiolitis, and foreign body, evidence of foreign body. And also can do an echocardiogram to rule out cardiac causes. Okay, next, I think I provide with pictures. Yes, is the first, these pictures of the right upper lobe pneumonia. These are taken from the Rhidopedia. So there is a whitish opacity at the upper lobe. Next, okay, this case of acute bronchiolitis, there is lung hyperinflated. So how we want to look? Anteriorly, count the ribs more than 6. Posteriorly, you need to count more than 10 ribs. Okay. Next is a picture of the thumb sign in case of acute epiglottitis. Okay. Next, steeple sign. You can see the church stick one at the trachea. This steeple sign in case of croup. Next, so this management. So the principal management, when patient presented with shortness of breath, of course we need to resuscitate the patient. So first, airway, secure the airway. This patient, if conscious, then we do a jaw thrust. In case of patient child is unconscious, we do a chin lift, and then make sure there is no obstruction. So do a suction to clear the airway, and then provide the adequate ventilation, give oxygen support, and at the same time we need to measure the pulse oximetry. And then C for circulatory, prepare the IV line for fluid and medication. And then once we resuscitate patient, also monitor the hydration and also the vital sign of patient, and treat the causes. So if patient are feverish, give antibiotic. If it's suspected, in case a patient having a bacterial infection, give a broad spectrum antibiotics. And of course, we also need to encourage patient to having oral intake. Okay, next. So I think that's all from me. Any question?
Okay. Any questions now? No questions, then we can just wrap up the class. I'm supposed to have I think bedside teaching with group 1 on group 1 or group 2. If no questions, then
Next week,
everybody can leave except for group 1. Next week tak ada kan? Oh, yang tu procedure seminar kan? Yang bedside teaching 15 hari tu dengan group 1.
Basic teaching ni mulai bulan.
15 hari bulan. 15. Bedside teaching group 1. Okay, yang lain boleh leave, tinggal group 1 je.
Thank you,
Yang
Doctor.
procedure
Doctor.
seminar tu group
Week
group berapa tu?
Oh, Dr. Chan.
Procedure seminar dia orang tak tulis group apa?
Procedure seminar.
seminar 3 je.
Group 1 juga Dr.
Group 1 juga. Okay. Yang lain ni boleh leave. Tinggal group 1 je.
Okay, thank you, Doctor.
Your marks I'll give to Farah directly. Group 1. Group 1, 7 je. 7 orang je. 7 orang je. Oh tak, 8. Nah,
8
ada 2 orang
saya.
je.
Ah.
Okay. Okay. Kalau petang tu, okay, first stick is the bedside teaching kan. Kalau petang tu memang I cannot. So it's either Monday, Tuesday or Thursdays at 7:30 AM. Okay. I will finish by 9 o'clock. So whatever case-based seminar or procedure seminar you have, you can make it in time. Faham tak? Jadi tengoklah korang nak hari Isnin, hari Selasa atau hari Khamis. Pukul 7:30 pagi. Pagi tau. Okay, bincang sama sendiri lepas tu beritahu saya. Okay? Siapa group leader? Ha? Saya tu siapa?
Saya Doktor.
Saya tu siapa? Ayuni. MS Samba tu nama betul ke nama
saya. MS tu medical student. Samba saya.
Samba?
Nama saya.
Memang nama lah. Nama penuh?
Yes.
Nama
Muhammad
penuh?
Mustafa Samba.
Muhammad Mustafa Samba. Okay. So Ayuni kan? Ayuni masih saya.
Yes, saya. Okay. Doktor, next week on Wednesday, 10 AM tu have procedure based seminar. Doktor available ke?
Yang tu boleh.
Okay.
Tajuk apa? Which procedure is it? Tajuk apa? Tajuk apa seminar tu?
Kejap.
Tajuk dia arterial blood gas, venous blood gas, capillary blood gas, central line and urine culture and sensitivity. Okay. Kalau nak tunjuk slide boleh, tapi yang at least yang pentingnya kena tunjukkan video yang mana kamu nak guna. Sebab saya nak pastikan video tu okey. Sebab kadang-kadang tu video yang korang guna tu tak okey sangat lah. Okay? Cuba cari video yang... Sorry? Ayuni? Sorry. Ayuni tak dengar.
Nanti kita orang send the link. The link itu yang the video.
Link apa? Link video. The video, you send it to me individually. Hantar secara individu melalui WhatsApp. Okay, yang penting saya nak tengok video sebab saya takut kamu guna video yang kadang-kadang tu dah outdated. Okay, cari video yang sebaik-baiknya untuk pediatric. Okay, I know the arterial blood gas dengan video puncture sekali kan? Tajuk tu.
Tak, ABG dengan venous blood gas. Venous puncture lain.
Saya tahu yang tu susah sikit nak cari untuk peds, tapi cubalah. Ada, saya tahu ada. But I'm not looking for you guys because last time I used to, after a while, I look for you guys. I don't think that's the way it should be lah. You guys cari. Okay, it's like basically less than 10 minutes on YouTube. You can find a few videos already. Okay, so cuba cari yang pediatrics. Cuba cari yang up to date sikit sebab sebelum ni ada yang pergi guna video yang dari third world countries yang tak ada iPad. So diorang pergi basuh tangan dalam basin, sterile equipment semua yang sterilkan kat rumah. I mean I mean not appropriate lah, kan? Okay, so just at least by hari Rabu kan, at least by hari Isnin pagi. Okay, at the least the video. Kalau tak siap slide tak apa, ataupun kalau nak tunjuk nak tunjuk rangka slides tu, your outline je boleh. Okay, but I want the videos. Okay, tu je. Bye bye.
Okay, Doktor.
Thank you, Doktor. Thank you, Doktor.